Joining me today is Andrew Koutnik, who is a PhD research scientist studying the influence of nutrition and metabolism on health, disease, and performance. And he's also a great friend of mine, mentor, and all around just amazing person. So I'm really excited to have this discussion today because as a type 1 diabetic yourself, Andrew, you have a very unique perspective of the inner workings of the human body, and you have a lot to offer, and it would be a crime not to record our discussion because I have so much I want to ask you and learn from you. So to begin, why don't you just introduce yourself, tell us a little bit of your academic background and your personal story.
Excellent. Well, Christy, honored to be here. I'm excited for what you're going to do to the world and have been. So as people become more aware of it, I think it'll only become more impactful. So I'm very honored to be here. A little bit about our research background. That's the first question. I started my research background at Florida State University. I was in exercise science. When I first started working in research in general, I didn't actually hand it out to go that way. I just went into a degree that I had passion in, and I was extremely passionate about exercise, nutrition, and how it can change your physique, your performance. And that's what really started for me. And honestly, as a young kid, being overweight, and I think at one point I actually crossed the obese BMI threshold. By no means was that muscle. I crossed legitimately because of obesity as a young kid. And you know, I had keen interest as a young kid. You know, you hear people say, "Oh, you're overweight." I mean, it eats away at you, self-image, self-consciousness, your self-esteem, etc. And leaves a big imprint. And of course, lifestyle nutrition, as we can all appreciate. I think most people without any expertise in this world can appreciate that those are impactful on improving physique. So I gained a lot of interest in it, and just personally, my family's always been into exercise. My father ran marathons before. My uncle has ran marathons, climbed mountains, done multi-century rides. Our family's always been into exercise. But actually changing your weight and physique, it's a whole different journey. It's not easy. It's a very hard thing to do. Most Americans fail to maintain any progress if they ever make it on the weight loss journey. So I had a lot of passion as a young kid for those reasons. And lost weight, eventually got into exercise and lifting weights and changing my body composition. I saw the value in these tools, these lifestyle tools. And I think this will be important for future discussion, things that fall into the modifiable factors, lifestyle. But they're not pharmaceutical interventions or any of these other things, but are effective, and we know they are for a lot of things, not just losing weight and improving your strength or your physique. And so I went to Florida State, and I was in anatomy and physiology class, and I loved it. I loved it. And I had an amazing professor. His name was Marcos Sanchez Gonzalez. He was an MD getting his PhD, and I just loved the way he presented. He taught extremely well and loved what he did. And I went and spoke to him afterwards because I thought I wanted to be MD. That's what I thought I wanted to do. And I went and spoke to him, and he's like, "Why don't you come and, you know, get involved in the lab and work a little bit?" I was like, okay, you know, sounds okay. And I got involved. And initially it was a lot of like basic work. It wasn't like super exciting stuff. But once you started realizing the translational impact of the more you knew, the more interesting it became. And eventually you realize like this is the foundation of what we learn about in the textbook, right? Someone reads a textbook and sees information that came from somewhere. Even if it's one sentence, it might have involved a year-long plus effort of the research group trying to answer that one question and then provide that sentence. So I grew a lot of passion to it. Started exercise science in cardiovascular research, then went into the interplay between how one's psychological health and overall health in general impacted their various systems like skeletal muscle, cardiovascular outcomes, autonomic function, stuff like that. And that's really why I started my research training, and then actually developed some of my own independent projects while I was there, and then transferred to work on from the cardiovascular lab to a cognitive psychology lab, working with how the mind interacted with the body system. And then also the College of Medicine, the cardiac biomedical lab, where we looked at looking how cognition and other factors, in fact, the morphology of the heart, things like depression, etc. That's where I started. But my passion had always been there for things like nutrition and those factors. Because what I really grew my appreciation at Florida State was training, development of research ideas and questions, and the interplay between how basically all aspects of your psychology to underlying disease states to et cetera have overwhelming widespread impact on your physiology and body. But I was extremely passionate to work on something that I knew had impacted my life. When I was actually right before I joined Florida State, I was at TCC. And while I was going through this journey of losing weight, I got diagnosed with type 1 diabetes. And at the time, I didn't really know a whole lot about that.
Wait, how old were you?
16 going on 17. So I was still in my late adolescence. A lot of kids are diagnosed, on the mean average diagnosis, a bit earlier than that for most type 1. But I still fell into the adolescent category, which is where most type 1s are diagnosed. But my journey with type 1, and that's something we can go into more detail about, I'm sure we will, is really what drove me to my next step in training, which is to join USF College of Medicine, Metabolic Medicine Lab. I was lucky enough to earn a fellowship to join there and study that focus, which is how is nutrition, but more so not necessarily nutrition, but nutrition as a tool to affect metabolism. And what were these widespread implications of adjusting metabolism to one's overall health? And it became abundantly clear, and I think has been appreciated for a long time, that metabolism has a huge impact on overall health and well-being, and something that has developed in through their own fields, like the field of tumor metabolism is something that has really recently emerged over the last decade into its own subset of study. Something we also were involved in, and some of my work was also involved in while there, but obviously we know that this can impact many diseases, not only the onset of the disease, but also the management of it, but it have clear implications across other things like performance outcomes, cognitive, physical, et cetera. And that was an incredible experience. And from there, I've been able to work with both USF and IHMC, Institute for Human and Machine Cognition, working on various research projects all the way from animal to human-based efforts, and trying to translate a lot of, answer as many of these important questions as we can, try to do relevant work that addresses questions we have from a health perspective, performance perspective, but also just underlying disease perspective. And this is a very personal curiosity to me that has a very personal story, as living with type 1 diabetes can give you quite the in-depth experience on how impactful metabolism is every day, honestly, almost at every meal. And you feel it, truly. You truly actually feel the impact of lifestyle decisions all the time. So I hope that answers your question from my journey from Florida State to USF to eventually working on various projects related to those same areas of topic and beyond. So.
Yeah, wow. You have a very extensive background that I didn't even know about. I met you in Dom's lab, so I know you from your USF and on. So I didn't actually know much of that other academic background. So that's really cool. But yeah, let's dive into the type 1 diabetes topic. Okay. Why don't you just explain the difference between type 1 and type 2 diabetes, and then we'll go on from there.
The quick and, yeah, absolutely. So the quick and dirty on that is type 1 is a pathological an autoimmune disease, or at least believed to be an autoimmune disease. Factors kind of trying to be determined as to what is the most important contributor to that, nature versus nurture, so to speak. But ultimately, the end result of all this is that the beta cells of the pancreas eventually get destroyed by our immune system and destroy the beta cells in the body that produce insulin. They're also the same cells that detect glucose levels in the body and then respond by secreting a certain amount of insulin corresponding to the absolute glucose level. So if you don't have type 1 diabetes, your body should be able to eat food, have elevations in glucose that almost immediately be detected in your blood sugar, and then your beta cells will absorb it, the glucose, do a signal output for that to say, okay, this amount of glucose requires this amount of insulin, goes direct in your bloodstream, and then helps shuttle the glucose out of the blood into peripheral tissues, controlling your blood sugar on a very regular basis. For me, I don't have that capability. The beta cells don't one, effectively detect it, and two, release insulin correspondingly. So I'm now my own pancreas. I manually check my blood sugar with tools that are available for patients like me now, whereas a decade ago might not have been as readily available. They usually use just urine, glucose in the urine. In fact, there's interesting stories about that, historically speaking, but that's the foundation of this disease. You have pathological obstruction of the cells that detect glucose levels and correspondingly manage them with insulin secretion. Type 2 diabetes has a lot of overlaps. It's a disease that ultimately affects glycemia in the body, of course, at least, but other things as well. There's a lot of lifestyle contributors to this, but there's also nature versus nurture. There's also nature involved in this, or genetic predispositions for people with these disease states. But ultimately, that is insulin resistance, so that you do have the ability to produce insulin, but your body is resistant to it. So you're just not as effective at actually utilizing the ability to, yes, you can actually give and respond to glucose levels with insulin, but the insulin is just not as effective. Things like obesity, inactivity, et cetera, are contributors to that, but there's lifestyle, or not lifestyle, those being lifestyle effects. But we also know that things like a genetic predisposition, if both your parents have type 2 diabetes, your risk is exceptionally high that you will develop that pathology as well. So it is insulin deficiency for type 1, me, and then insulin resistance, which is type 2. Now, there's a whole nother story about how patients might have both, what they call double diabetes. Although it's kind of hard to detect, of course, you'd have to have type 1 and then also develop an ever-growing resistance. But those are the distinguishing categories between those two diseases. The whole story behind how that was discovered is also quite interesting, all the way back to 1960s, actually 40s, 50s, and 60s, looking at the discrepancies across patients. Because at one point, there really wasn't much of a distinguishment between patients at all, besides young versus older onset and phenotype, young and skinny and losing weight, and overweight and obese and having glycemic-based issues. So, but we still have these diseases, and they still are prevalent in our society, and unfortunately growing in prevalence as well. So,
is type 1 diabetes also growing?
The incidence, to my knowledge, is increasing. I don't think it's quite at the same level that things like obesity and type 2 diabetes. In fact, I'm almost certain it's not. The number not too long ago was 1 in 300 have it. It tends to be a disease of what they call a disease of wealth. Now, being wealthy doesn't give you a disease, but just the idea that Western cultures, those who fall typically into certain class structures are more predispositioned to them. It's more common in Caucasian than it is in, say, African American, et cetera. So, yeah, it's, did that address your question?
Yeah, I just wanted to know if there was an increased prevalence of type 1 diabetes.
So, to go a little bit further on that, we do know, it's interesting because a lot of times, there's a whole nuanced conversation in itself, but that's growing in knowledge, and I think there's actually a lot of opinions on. In fact, there's some big research studies underway right now that just got funded to kind of further evaluate this. But some people believe, well, here's the thing, is that we now know that type 1 diabetes doesn't just happen in adolescence. That was once a held belief. But we know that things such as LADA, late autoimmune, like basically type 1 diabetes in older age,
okay.
Where people in their 30s, 40s, and beyond can actually start developing beta cell destruction that isn't type 2 specifically, that have antibodies against, or have indications they are type 1, that define that they are type 1, even at this late stage. They don't fit the characterization perfectly of type 2. And as a result, they actually do have type 1 later in age, and that's growing in incidence. Now, whether that's growing in incidence because we actually know what it is and that we can detect it is a whole different question, and a very nuanced one. But we know there's multiple types of type 1 that would have initially been diagnosed as type 2. In fact, that diagnosis is often not always perfectly diagnosed. A lot of type 2s actually are type 1s and people don't know it. And that's its own question. So something that people have way more expertise than myself on, because that's a very growing field and a very passionate one too. But it's multiple things. That one, we're more aware of the disease and what actually can detect. And some people actually believe diabetes as a whole is a spectrum-based disorder. where you have spectrums of different categories. Type 1 adolescent onset, you have MODY, you have LADA, you have type 2 diabetes, and some that are kind of nuanced in between. So that's kind of a lot to say that there's distinguishing categories between them. Are they growing in incidence? Type 2 seems to be, obesity certainly is. It seems to be growing in prevalence, not just in the United States, worldwide, and probably following the obesity epidemic that's also growing in incidence and also growing worldwide. Type 1, to my knowledge, some evidence indicated that it is growing in incidence. It is a question whether that's actually because of greater awareness of what is type 1 or because there is actually a true increase comparative to the past.
Yeah, I was thinking of it in terms of like if type 1 was increasing in prevalence, then maybe there is some sort of lifestyle component that's triggering this autoimmunity.
Yeah, and there's a lot around that. There's a lot of people who are very passionate about trying to uncover that, what is happening to that. In fact, one of the biggest financial investments from NIH recently was in a trial called TEDDY, which is run out of USF actually, with the likes of other institutions around the world, and looking at what are the multifactorial onset factors contributing to the onset of type 1 diabetes. And to just say, we have indications of believe certain things may be contributing in risk, but nothing's 100%. So even if you have identical twins, one has type 1 diabetes, one doesn't, that doesn't seem to be explainable by the genetic only hypothesis. We know there are scenarios like that. So at the end of the day, it's something we don't completely understand. And that's why I say when I first said, what is type 1 diabetes? We believe it is an autoimmune disorder caused by this, and this, both environmental and genetic onset that we don't completely understand. But we hopefully will have greater resolution on that with some of the studies actually out of USF group. So we'll see. Worldwide effort. We'll see how much that helps.
Wow, that's cool. Okay, so let's talk about management strategies and what's available today, right now, for type 1 diabetics. So say I was diagnosed today with type 1 diabetes, what is the standard dietary recommendation that I would probably receive? Like, what's the most common dietary strategy that people are given when they are diagnosed?
So that, so I'm going to try and answer that in a history way, because you mentioned diet, but there's so much, although we know diet is one of the most potent lifestyle factors that contributes to one's glycemic control, that's only one aspect by which one can define therapies for management of type 1 diabetes. So if we look back over a century ago, before the discovery of insulin, people would often show up to a hospital with type 1 diabetes, probably because they're in ketoacidosis, almost certainly, and sick, wasting away, and have glucose in the urine. So you can actually read like old stories of in cultures where they didn't have these tests. Individuals would, as crazy as it sounds, urinate on the ground and see if ants would migrate towards their urine to see if they were above glucose levels or not, because it would spill out into the urine once you're above a certain level. And of course, when you have type 1 and your beta cells are destroyed, your chances for elevated levels in the blood would be higher and your kidneys would secrete more. Mm-hmm. So at that age, pre-insulin, there was use of these tools to distinguish between more or less in the urine. And ultimately, that's not such a bad biomarker, right? Even though it's rudimentary comparatively to now, it does tell you if there's spillage of glucose in the urine. That's one of the hallmark signs. That's also why a patient like myself, when I was first diagnosed, was going to the bathroom almost on the hour all the time, very thirsty, telltale signs that you actually have type 1 diabetes or getting it. So when we talk about, different dietaries, or you said diet, but different strategies. So in the pre-insulin era, there's a lot of things done in the moment when you got diagnosed. So there's tools that they were given, things like even like cod oil, et cetera. But things to buffer the acidic load was the very first strategy to try and get patients beyond the initial stage of DKA, because if you didn't make it past DKA, a lot of patients just die within the first week. So that was, first is just buffering that. Then actually what was used over a century ago to extend the life of patients with my disease prior to insulin management was fasting and low carbohydrate diets. The reason for that is because they noticed that higher carbohydrate intake appeared to exacerbate the disease and ketoacidotic incidence, which would make sense, right? If you don't have beta cell function, you consume more carbohydrates, that would exacerbate the pathology that is driven by elevated glucose levels and lack of insulin. So when you think of DKA, DKA is a host of circumstances, but often it's with one metric to look at is blood glucose levels over 250 milligrams per deciliter. Obviously insulin deficient, ketone levels pathologically elevated and uncontrolled, etc. But glucose levels.
What would you define as pathologically elevated?
So for the type 1 diabetic, it depends on the circumstance, dietary circumstance. That's something that will kind of tie into your previous question. A type 1 diabetic who's doing a standard diet right now with current management strategies, they would often look for a millimolar level of the blood of over 3 millimolar. But obviously, there's a problem with that. If someone's on a nutritional ketosis diet, we know that 3 millimolar is actually well within the range of normal therapeutic dose or therapeutic millimolar levels for that nutritional strategy. That opens a very nuanced conversation because it does depend on the dietary strategy you choose. You can't just inadvertently use a level of 3 millimolar as a diagnostic criteria. There are other things that play into DKA to be diagnosable. But if you're not on a low carbohydrate based diet, typically greater than 3 millimolar has strong evidence to indicate that that is actually indicative of DKA or is one of multiple signs that you have DKA. You can use pH blood levels, you can use anion gap, you can use weight loss, et cetera, et cetera. All these other things that can contribute to, does this person have DKA? Obviously, if you stop taking your insulin, insulin deficiency and all these other things that can play into that. But it is very contextually dependent because there are patients who are at a growing prevalence or interested in a unique dietary strategy to manage the disease, which is something we can talk about. But the range is 3 on a standard, higher than 3 on a standard diet is a known criteria, threshold criteria, or established one across many scenarios. But if you're on a low carbohydrate diet, which is something we can talk about here in a second, and I'll tell its history story into that because it's actually a really interestingly important part of the story of type 1 diabetes management. But so to that original point, when patients were pre-insulin, were using these strategies like fasting or otherwise to manage their disease, they were doing so because it was extending the life of the patient. Giving more carbohydrates would exacerbate the disease state in that status. And there were some studies in 1921 looking at, can you add more protein or more fat into this diet to sustain the patient longer? Because ultimately, when you are fasting and starving chronically, what's the end result of that? Well, you can't go into a caloric deficit forever without it becoming, dangerous and fatally, because you can't, at some point that can't work. And patients would actually get to the point in the pre-insulin era, and there are stories of this, of patients literally going to the point where they emaciate to death. So then the low carbohydrate diet came into fold as an idea of a mitigative strategy that doesn't require full-out starvation. Then the idea of bringing more protein into the mix and more fat into the mix. These are all pre-insulin era strategies to manage disease. Diet was a huge portion of that. But this is all pre-insulin. And then a lot of the other tools were managing the acidic load when someone developed DKA. However, what happened post-insulin era? So in 1921, insulin was discovered by an individual named Banting, and there's a whole interesting story around that as well. It's not just Banting, but other individuals that played into that discovery. And that kind of changed completely the outcomes of someone like myself. I'm standing here talking to you today, Christy, because of insulin. If I didn't have insulin, I certainly would have not survived at this point. I'm now almost 14 years. Now I'm over 14 years, I think, at this point, as of August, for type 1 diabetes. I wouldn't be here today more than likely. The stats universally showed or consistently showed that you were expected to live certainly less than 5 years, and oftentimes you wouldn't make it out of the hospital to begin with once you're first diagnosed. Wow. So in a post-insulin era, obviously things are much better. But there has been a shift in dietary strategies, but also technological advancement over that period of time. So once insulin was discovered, dietary strategies started to loosen. The question was, is it required anymore to have such a restrictive diet to manage this disease? That's something we can talk about here in a minute. But there's also advancements of more refined insulin strategies or insulin types. So now we have all sorts of insulin options. So rapid, regular, basal insulins. Each one of those categories has a number of insulin options available to it. We even have inhaled insulin now, et cetera. So that development happened over time. We also developed things like pumps. So tools that actually can sit on your body and manually release insulin like it's a superficial outside the body pancreas. So that developed some years back. And then the CGM technology, which is something called a continuous glucose monitor. I have one on my stomach here, and I have a toolkit that gives you a readout on a regular basis. There's many options, Abbott, Medtronic, Dexcom, amongst others, are very interested in these tools, not just for pathology, but non-pathology for a whole host of reasons. But yeah, so that tool came about, and it gives you indications of your blood sugar on a regular basis. This is a huge deal for a type 1 diabetic to have a continuous evaluation of how your blood sugar is doing. Maybe not even just for the type 1 diabetic, for type 2 or for the healthy person, but really for the type 1, because at one point you only had individual prick values at single time points. So you don't have the resolution of detail to say if I ate this type of food or if I engaged in this type of activity, what was actually happening to blood sugar levels. This tool really revolutionized awareness of lifestyle choice and what's happening to your blood sugar level any day, on a day in and day out basis throughout. And things like merging these two technologies, they call it sensor augmented pump. So you use your pump to inform your pump or your sensor, your CGM sensor readouts to inform your pump use. And now they have tools where they're actually creating algorithms to match both. So it's automated for the patient at present. All these are great advancements in tools in type 1 diabetes, for sure. They definitely help the patient. It's a whole different conversation to discuss, unfortunately, how even with the advancement of all these tools, we actually do not see an on average improvement in glycemic control, even with those advancements. But then that's a whole different conversation. But to talk about the other aspect that you already brought out, which is diet. And I talked a little bit about diet in the pre-insulin era, about how it was used to extend the life of the patient. But the constraints on diet kind of really fell out of favor. The idea of restricting a diet after the insulin discovery, because it was largely felt, and there's literature to even show this, the opinions of individuals at that time and how they portrayed the research findings or even give perspective opinion pieces. It was largely felt that there's no need to be restrained anymore on diet as a tool in the management of type 1 diabetes. And that was a long-held belief, at least based on the average perspective opinion that you could draw from literature at that time. But the issue, well, not the issue, so it fell out of favor. So you actually saw a progressive increase in the amount of carbohydrates consumed and or recommended by governing bodies like the ADA, FDA, USDA, et cetera, for the general population, but also for diabetics. The problem is that there really hasn't ever been an RCT, randomized controlled trial, to validate what diet is actually optimal for a type 1 diabetic. So what has happened is that the diabetic patient, at least when I say diabetic in general, type 1 diabetes, has been following the general guidelines for the normal population. So that has happened over time. The only issue with such a thing is that the pathology of not only type 1, but also type 2 isn't analogous to a type 1 scenario, right? There's a whole host of other factors that contribute to this. That's particularly true in type 1, where your food choices has one of the most potent impacts on your glycemic control on a very acute basis. And the theory is, the jury is out on a chronic basis, although there's some indications that that may also be the case. But essentially it's fell out of favor. But there's been a whole reemergence of diet, and I'm going to focus on that here for a second. Recently, in fact, we did an unbiased Google analysis. If you search diet in Google Trends right now, just diet, nothing else, and actually look at what are the most commonly related queries or related terms, you can actually see that things related to carbohydrate restriction make up the #1 dietary strategy or search dietary strategy since Google Trends started collecting data. So that's important, right? Because that indicates, at least in some way, global interest. But we also see that if you search on PubMed, low carb or ketogenic, and search engine for PubMed, you see that the arrow of interest has gone like this. And we actually see that even this year, the amount of publications produced will likely far exceed the previous year. Something that's happened almost progressively for the last 2 decades across both those categories. So the public interest has grown, generally speaking, across the world, at least based on Google Trends. And we also see that that's also been the case for PubMed, or scientific interest based on citation number. But we also see in publications related to type 1 diabetes that patients have specifically expressed interest in these dietary strategies for a whole host of reasons. In books, a lot of books have emerged on these strategies for type 1. So diet has really taken a re-emergent front stage in the context of not just diabetes in general, type 2 and type 1. Type 2, there's well over 70 studies looking at carbohydrate restriction strategies for that. There's a lot less in type 1, something we're actually trying to find better information on and greater resolution on. We'll see what comes out of that. But at the end of the day, diet is actually front and center. The only issue is that we don't necessarily have the same resolution of information. Now, there has been some to inform type 1 diabetes outcomes. Again, this RCT for dietary recommendations just really hasn't happened. Mm-hmm. But that's just to answer your question on the concept of, since pre-insulin era to now, therapeutic strategies has largely gone with initial management from nutrition, medical nutrition therapy, which took front and center pre-insulin, has kind of faded with time. Whereas pharmacological interventions and technological interventions have largely gained an interest over time. There are others, is this re-emergent interest all of a sudden recently, probably due to global interest of management strategies for type 1 using nutrition again. But the problem in general with the shift that's happened up to this point is that it actually hasn't improved glycemic control meaningfully. In fact, we saw from a 2008 or 2010 to 2018 analysis from Foster et al., which is from the Type 1 Diabetes Exchange, one of the best data sets, if not the best data set in type 1 diabetes across institutions in the United States. We see that outcomes, even with advancements of or technological interventions for HbA1c, this chronic metric of glycemic control, is getting worse. So that opens a whole can of worms as to, well, what do we do now? Because these advancements in technologies were seen as the future, and they're not making it, at least for whatever reason, it's not getting better. And so yeah, that's where we're at with type 1 diabetes now with therapies from pre-insulin to now.
And the idea, like why it fell out of favor, was because doctors were like, well, why would we tell them to reduce their carbs if we have insulin? They can just take more insulin. Was that the idea?
Well, imagine, and this happened with me, right? I go into the hospital when I get diagnosed, and the doctor comes in and is going to have to level with Andrew Koutnik that his life has changed forever. He has a chronic disease that won't ever go away. And he's going to have to now manage that by taking, imagine Andrew, sitting around public park or in the gym, and he pulls out one of these and he sticks it in his stomach or his shoulder. What's the first thing that's going to cross everyone else's mind? If they're aware of diabetes, maybe diabetes, but not necessarily is that going to be the first thing that goes to your mind. So as a patient, I'm thinking, okay, this is all going through my head when I was first diagnosed. Imagine someone also says, okay, we're leveling you that you're going to have this chronic disease. We're going to prick your finger every day, with tools like this, and you have this little, you probably can't even see it, I don't know. And there we go. So that's the needle right there, right? It goes into your finger every time you test your blood sugar. It's whatever. It's like nothing nowadays, but at one point it seemed, oh Jesus, I do this all the time. And then you take something like this, and this is the smallest needle I think that's pharmacologically available. You can see it maybe a little bit. That you stick wherever, your shoulder, if you're sticking your adipose tissue, your muscle, whatever, for whatever reason you're choosing, for the rest of your life. So then you're leveling with the patient, they're doing this, and then, oh, by the way, what you eat every single day is now going to have to be mathematically calculated in some way for you to be able to then give insulin. So right now when a patient leaves a clinic, and this is a question you had before, which ties into this, is when I was first diagnosed 10 years ago, which is largely, it's largely overlapping to nowadays, a patient is taught in the clinic, how do you prick your finger? How do you test your blood sugar? How do you use a syringe to put it into a bottle to then inject the appropriate amount of insulin? Well, what's the appropriate amount of insulin? Well, what you're taught is that the food you consume has a huge impact on it, specifically carbohydrates. That led to the standard of care, which is usually implemented nowadays, which is carbohydrate counting strategies, which is for like, let's say 1 exchange unit, or like say 10 to 15 grams of carbohydrates, which eventually becomes personalized and individualized for the person, but that's like where you start at, would require, let's say 1 unit. And then you go on from there, right? But that's what you're taught right off the bat, is how do you just manage your disease every single day. But one thing you're taught immediately is that your nutrition matters, and that it's going to matter every single day. The only other major thing that you're managing is, around your blood sugar level on a regular basis. So is my blood sugar high or is it low, and how much does that play into the dose I need to give? So it's really a combination of where it's your current blood sugar level at every meal of every day. What's your current blood sugar level, and then what's in your food. We know that fat's largely not going to impact your glycemic level at that meal, except maybe delay the absorption of it. Protein has a modest effect on insulin levels, dose dependent as well, up to probably a certain threshold of digestion threshold. And then we know carbohydrates are dose dependent. They are arguably the most potent lifestyle factor on elevating postprandial hyperglycemia, and more than almost anything. In fact, the only comparable thing to carbohydrates as far as how impactful they are on your glucose levels acutely is maybe glycogen, which is injected. And I don't know if there's ever been a comparison between direct injections of glucagon versus direct infusion of glucose. I don't think that's ever been done to do a true comparison. But I know that glucagon per dose and carbohydrates illustrate the two most impactful tools to induce elevations in glucose levels. But for the normal average daily lifestyle, carbohydrates are the most potent lifestyle factor on postprandial hypoglycemia, meaning at every meal, that's the biggest factor for the patient, and has led to the standard of care when you leave the hospital, still the case, which is carbohydrate counting strategies, which is measuring the amount of carbohydrates you can anticipate in that meal with how much insulin. So essentially, a type 1 diabetic needs to immediately become an expert on their nutrition and their body's response to not only their nutrition, but their insulin as well. And that is a very complicated, nuanced factor, or there's a lot that goes into those factors. The absorption of the insulin rate. Well, was I active that day? Is my skin hot? Am I about to take a shower? Am I walking out in the heat? Have I been taking medications, caffeine? Have I exercised? This is just a very small list. You could probably come up with over 100. In fact, there are lists on the internet right now of all the factors that go into this. I could talk a lot about that, but I'll just say that is a lot that goes into the management strategies. And right now, that's our standard of care for type 1 diabetes.
So we know that carbohydrates are the most potent changer of blood glucose levels, but when someone's diagnosed, they're just told how to manage carbohydrates in the diet, right? Like you're not really, the standard of care is not to say, okay, limit this potent changer of your blood glucose. It's take this amount of insulin to manage that load of carbohydrates. And how,
Actually, yeah.
so knowing that, how has that changed your dietary approach? Did you start on a higher carbohydrate diet when you were first diagnosed? And how has that changed as you've learned about nutrition and metabolism? And what is your dietary strategy for managing type 1 now?
So, so I will try to answer all that in a sequence because I feel like they all tie together. The thing that you are taught when you leave the hospital that, okay, you use insulin to match what you eat. It's not usually viewed the other way around, which is, here's your tools that you have to manage your glucose levels. Eat to match how those work. Because I will tell you that these tools that I currently have are not necessarily perfect matches. In fact, in some ways, very far from it to the current foods and how they work in the body. So the kinetics of the medications we use have never really been made to match the kinetics of things like carbohydrates. That's one big issue with these tools. But that is what is taught. But that's the idea, right? Like what else are you going to do? And what other strategies are there to do? I mean, that's what you have available to you. So that's what you do. You continue to live as healthy of a life as you can. You try to make food options that are better. And at the end of the day, you just try to manage as best you can. That's the option patients are given. But that's not necessarily the approach I always took. In fact, the reason I maybe chose a different strategy is a very personal one, and laid back, or it goes back almost 12 years now, a little over 12 years. Because when I was first diagnosed, I just continued what I was eating prior and just try to manage as best I could my blood glucose levels. I think when I was first diagnosed, my A1C was like somewhere between either 7 or somewhere between 7 and 8. It might have been 8 when I was first diagnosed. And then we start taking insulin, you start, we bring it down to a more manageable level. Most patients sit around 8.2. That's a whole different conversation about where we are at as type 1 diabetes. But for me personally, as a community, for me personally, my dietary strategies drastically changed about 1.5 years into my diagnosis. And the reason for that is because I had heard of, I was big into fitness. I was big into nutritional interventions to fitness. Now, I was not an expert by any means at this stage, right? I had no idea what was ideal or not. I just read articles online and, oh, this guy looks like he knows what he's talking about. This girl knows what she's talking about. Well, they had to say something about this. Let me check that out and try it. So I was very self-experimenting, still am to this day. Kind of is the life of a type 1 diabetic. You can't really get away from it. You can try to. It doesn't end well, though. But I had heard many stories about, low carb at one point for bodybuilders. And I was very big into bodybuilding at one point. And at one point, almost like framed my entire existence, as it does for a lot of people who get into it heavily. But I had heard, okay, try low carbohydrate. It can, help retain muscle in the caloric restriction. Now, that's a wholly different conversation, because honestly, that ended up being a central focus of some of my PhD work, ironically. But it's actually what initially got me to try the carbohydrate-restricted diet in the first place as a type 1 diabetic. So I often reflected on the vast irony of such a situation, of my lifestyle playing directly into what I actually had done for research. But I said, okay, screw it, I'm going to try it, right? Like, what do I have to lose to try it? So I actually reached out to someone who was a type 1 diabetic bodybuilder, and just said, what's your take on this, doing this strategy? And this person said, well, I've done it before. This is some of the things that I've done as far as switching insulin types, and here's how I would start and adjust. And so I worked with this individual just to kind of try to optimize my initial transition into it. And it's amazing. My insulin, so I went on a low carbohydrate diet. By no means was I doing low carbohydrate by how it's defined, let's say, the seizure community or in the diabetic community. I wasn't doing any of those things. I was doing a high protein, high fat carbohydrate restricted diet. I was eating about 200 grams of protein, 200 grams of fat per day, and just like broccoli and spinach, et cetera, for veggies. So
what was your carb, do you think?
50 or less per day, for sure. Of fibrous vegetables, for sure. So I kept those pretty low, and I was now shifting away from taking, like, say, regular insulin, or let's say rapid insulin, like Humalog, Novolog, et cetera, to regular insulin. That's actually not the same as that brand. I actually use, not giving advertisement, this is what I do. This is Insulin Era. You can buy this for $25 at Walmart. I was using Insulin Era, but that's prescription-based, and that does the same thing, and that's $25. So I now use that. But I essentially shifted to using regular insulin because when I reduced carbohydrates in my meal, carbohydrates were no longer the most impactful aspects of my nutrition that were causing needs for insulin. So there's some studies from Collier in like 1980s, 1970s, way back, that were showing the different insulin needs for various food options. And they studied like protein doses versus meat doses, et cetera. And what they found in that study is, I think they compared potatoes to, I forget what the protein source was, but the same gram per gram dose, with or without fat. And what they essentially showed is that the protein needs insulin needs of protein were about 40% of that of carbohydrates. And they were prolonged. So it was less and more prolonged. Well, amazingly, this insulin, regular insulin, has a more subtle and more prolonged kinetics compared to this insulin, which is a rapid insulin. Why does that matter? Well, if you take rapid insulin right now, the kinetics, if you inject it into adipose tissue, on average, are about a 5 to 15 minute onset. Depends on the individual, depends on when you inject it, a whole bunch of things. the peak is typically at an hour, and most of the effect is gone by 2 hours. It has a tail that largely lasts for hours, but most of the effect's gone by 2 hours. Now, this has all been studied in a clinical setting at rested levels. That's where we derive that information. So it's a complete wild, wild west when you live your normal life and how that will work. It's very hard to predict. It's well known in the type 1 diabetes community that if I inject 1 unit today versus the next day at the same exact time of day, there is far from a guarantee it'll work the same way. In fact, we know it doesn't work the same within the day. We know that insulin sensitivity changes within a day. And there's a whole list of things I mentioned prior that can affect that too. But in essence, I think I'm kind of derailing off the original question here, but can you help me get back on track here with the
No, that's
question?
okay. I like these little tangents. I'm learning how the management and all the intricacies of management strategies work, but I mean, I kind of forget the initial question too. I think I just wanted to know about how you've evolved your dietary strategy. And actually, there were a couple questions in there. So you were saying that it was like 50 grams carbs, 200 or whatever protein and fat, but that was not ketogenic for you because of the amount of protein.
I actually have no idea what my ketone levels were at that stage. I was also like 240, 250 pounds at that stage. So keep that in mind when we talk about these gram dosages. I was highly active, also exercising for almost 2 hours every single day, at least, intense weightlifting, etc. I was doing cardio too. So keep that in mind. No general recommendations there, but I did eventually, so I tried that. And what was interesting about that is while on intervention, I switched my insulin strategies, used regular insulin for protein-based meals. I only used rapid insulin ever when my blood sugar was too high. That was my way of bringing it down quickly. But essentially, I wasn't really using much regular rapid insulin anymore. I was using basal insulin to cover my needs on a regular basis.
And so when you're using rapid insulin, you are injecting, there's a variance with it as you described. So that could be, and if you're needing that for a high carbohydrate meal, you're basically playing a game with your blood glucose and you don't really know how it's going to respond. Or like if the more rapid insulin you use, is there more risk of variance that could go in the wrong direction? And is this a problem with high carbohydrate diets with type 1 diabetes? And so
there's a lot of questions in there. And I think the big theme there is higher insulin risking it? Is it risky? Well, it depends, right? So the analogy I would always give with that question is, let's say that one day, Andrew, let's say one day I took 1 unit of insulin, right? And then the next day, or let's say I was eating a standard carbohydrate-based meal for someone of my weight and size, somewhere between 60 and 80 grams per day, or for a meal minimum, probably over 200, so my size, probably like pushing almost 100 per meal. I guess it really depends, like your metabolic status, those things. Let's say I did that. How much insulin would I need for that? Rapid insulin? Well, it really depends. Well, let's say it's based on this 15 gram dose. So let's say somewhere between around 7-ish doses or something like that. I'm sure someone will back calculate that and say it's wrong, but I think 7 is like close to what it would be for like 15 grams per unit. So let's take 7. Well, let's say I was a little more active that day. Or let's say I exercised for like vigorously for an hour. I might need to cut that in half. Well, the problem is that half might not be the right dose. Let's say I'm like, okay, I just exercise a lot. I'm going to have that same amount of carbohydrates. Normally I would give myself 7. It would be okay-ish. Does a decent job, but today I exercised and I think I need half. So I take 3.5 units of insulin. Well, let's say that I didn't actually vigorously exercise enough to really make a meaningful change in my insulin sensitivity or absorption rate or something like that. And I took half the amount of units. Now I'm off by 3.5 units. Okay, that's a lot of units to be off. So this is I don't want to say it's a game, because that will certainly trigger some people by using that terminology, but in reality, it really is gamifying your life to managing your own metabolism, glycemic control, using these tools as insulin, which are dangerous. I mean, it's extremely dangerous to under or overdo any dose. In fact, we know that some of the most acute complications associated with this disease are using too much insulin and going into seizure, coma, or hospitalization. The rates of that per year in type 1 diabetes somewhere between 5 and 15%, and DKA I think is somewhere between around 3 or so per year. One incident requires intervention per year for some severe event with mismanagement of insulin acutely. Chronic complications is a whole different thing, and is unfortunate what type 1 diabetes are set up for. But yes, acutely, these are all things that we have to consider. And why does that matter? Well, at the end of the day, these insulins they're very potent hypoglycemic tools, and we know that they're the best things that we have to manage this disease. And ultimately, like when we talked to the original question, I never really fully answered. I restricted carbohydrates. I was mostly managing my protein with regular insulin, and from that, it did an amazing job of managing my glucose levels. And the only reason I knew that is because I was barely ever testing it on the normal range in finger sticks. I went to my doctor's office and got an HbA1c test about 3 months into the diet. And he had told me, he's like, wow, these are some of the best numbers I've ever seen in HbA1c. I'm like, what do you mean? He said, well, it's 5.6 at that time. It's the first time I've ever done this first intervention. I was like, wow, okay. It's either 5.4 or 5.6. I forget the exact number at this point. But it was a non-diabetic HbA1c, like not even pre-diabetes HbA1c. He's like, what are you doing? And from there, it was like a nonstop journey in my life to understand how to further optimize my glycemic control, because it was also when I felt the best I ever had since I had the disease. When I was no longer outside of these normal ranges and constantly off this, what we call roller coaster. It's a common term used with glycemia for type 1 diabetes, because it's often up and down with each meal. So you go up because you ate food, you give insulin that doesn't really match the kinetics, so you go up and then it brings it back down, and then you're constantly playing back and forth. So yeah, that was largely what I did. And the reason I even considered a low carb diet, maybe not have been necessarily for glycemic control, but inadvertently caused amazing glycemic control for me. Interestingly enough, I started studying this for a whole host of other reasons at USF and beyond. And come to find out, now it's one of the most popular dietary strategies there is. And also the popularity in this for type 1 diabetes has rapidly grown. In fact, there's been a number of publications that have just come out in the last 2 years looking at these strategies about how effective they can actually be for type 1 diabetes management. And I really hope more do come to inform more about these strategies, because right now, the best outcomes I have ever seen in the literature right now do come from dietary-based interventions, very low carbohydrate diets specifically in the literature. In fact, there's nothing comparable right now as far as therapeutic strategies. So that kind of ties into the future interest on where things may go. Who knows? Hopefully there'll be a cure someday, Chrissy, for me. But speaking to some of the best beta cell biologists in the world, I don't think that that's coming anytime in the next decade, maybe in my lifetime. Although I hope I'm wrong, and I hope they're wrong. But I also have to level with reality. And as a result, I've been doing this strategy because it's just something that is the best thing I'm aware of that I can implement right now as a type 1 diabetic to help manage my glycemic control. I try not to be portrayed, by the way, as a side note, as Andrew's a low carb advocate, or all in low carb or keto advocate, or any of these things. I try not to be that at all. I'm trying to be a researcher who's unbiased on these topics, but I am a fan of what works. And at least for me, this is what has revolutionized my life, and also my family's life. They don't have to worry nearly as much about me going to bed and having to worry about, will I get nighttime hypoglycemia that's extremely dangerous or risky. These type of things, the lack of fluctuations is a common report anecdotally, and actually we start to see evidence that indicates such in the literature for type 1 diabetes, that these are things that these tool strategies seem so obvious, right? We're talking about one of the most potent lifestyle factors on glycemic control. Amazingly, if you reduce that, that all of a sudden it helps manage your disease better. I think it's kind of obvious, right? The bigger questions, though, come around, okay, well, is there safety concerns with reducing carbohydrates? Is it sustainable? And those are reasonable and fair questions to ask. But, for me as a type 1 diabetic, largely, why I even get out there and speak on these topics is I was hesitant to do so originally, for sure, for a number of reasons. I didn't want to be framed in a certain way, but I also know there's very few options for someone with my disease, and that's extremely unfortunate. So And it shouldn't be that way, but that's where we're at. So we have great tools, but they don't seem to really change outcomes yet. And hopefully that'll change. But I don't know, right now it looks like the evidence does seem to suggest that carbohydrate restriction might be a very potent tool in the toolkit, so to speak, or toolbox for managing this disease. And of course, as we talked about, Christy, for a whole host of other topics, it doesn't seem to just apply maybe to type 1. It seems to be something that's being evaluated for a whole host of other conditions. And in some people's minds, maybe it's something worth considering for the augmentation of the well person. But that's a very controversial topic, right? But I'll leave it at this, that there's a lot of interest. I think it's justified. I think it's justified further exploration. And we know that nutrition matters. We know lifestyle matters. We've known exercise is extremely important for health for a long time. I think hopefully at some point funding will come to support some of the most impactful interventions we know that can impact health that also don't require some of the toxic side effects that often accompany chronic medications or very potent medications. And like, for example, the carbohydrate restriction strategies that we were referencing before, they lower the amount of insulin the average person has to take. We know that. That's the biochemistry. You take less carbohydrates in, you consume less insulin acutely, but we know that also appears to be the case chronically. So you're reducing medications, you're reducing the most potent medication that induces hypoglycemia in your, on a regular basis, you're reducing the most potent postprandial hypoglycemic lifestyle effect. And, you know, those are really strong arguments for one to consider such an approach. But there's also other things that people are concerned about. You know, is this going to be a sustainable lifestyle forever? Is there safety concerns for protein related to kidney health, or my child, are they going to grow normally? These are all things that have been brought up involving this diet, which I don't think are completely far-fetched to have at least brought up and be curious about, for sure, based on how we traditionally understand the history of these diets in other contexts. But, you know, that can be a nuanced conversation in and of itself.
So you found that it's reduced your amounts of hypo and hyperglycemic effects or circumstances. And when you do experience hypos, are they less severe when you're fat adapted or following a low carbohydrate diet? Would you consider yourself like fat adapted? Is that a term that you would use, or like?
Yeah, and I could go like hour-long tangents for both those. Hopefully I won't. So hypoglycemia. One big problem in type 1 diabetes is that the fluctuations in hyper and hypoglycemia are so frequent that there's a well-known phenomenon called asymptomatic hypoglycemia, where patients no longer actually have awareness of going hypoglycemia. As you can imagine, that's very, very dangerous. So having adverse control, glycemically oriented, actually can lead one to be unaware that they're actually in this very dangerous physiological state. That's obviously a very big problem. I've noticed that actually there was one period of time where I switched off this diet in the last 14 years, where I actually tried something that caused my blood sugar to go up and down pretty dramatically. I tried it for a month, and I could literally, it was the worst. One being low carb, I've never had an HbA1c greater than, I think, definitely never greater than 6. It's been ranged from like 4.9 to 5.8, I believe, for the most part. Never gone above a 6. But the one time I actually was higher than that was when I was diagnosed and when I did this other intervention. I tried it just to see if it had physique-based performance outcomes. And I did become asymptomatic to hypos. And I also noticed that my thinking abilities were dropping. It was actually quite scary. And it's also the scariest moment for my wife to even try this intervention because it quickly became apparent that there was changes that were happening to me on a regular basis. We know there's things like irritability, lack of cognitive skills, et cetera, when you go hyperglycemia. And it's a whole different conversation, but important to mention. Patients live there on a regular basis. The average HbA1c is around 8, at 8.2. That's about 183, a little over 183 milligrams per deciliter mean average blood glucose if we translate that to HbA1c to mean blood glucose levels. If you look at CGM data recently for patients, about 160, a little over 160. So all that combined, most patients are living there. The deviation is around 60 milligrams per deciliter on average. So they're going up and down on a regular basis. I've lived there before, and I know how impactful that can be on a regular basis, and it is quite terrifying. Now, most patients live there on a regular basis, and it is very unfortunate that is the average for most patients right now. It is. But your question was about hypoglycemia, and a lot of patients actually, I'll say a lot. There are a population of individuals whose glycemic control has led them to no longer be able to detect or be asymptomatic to hypoglycemia. In fact, the whole field of study is how do you regenerate glycemic symptoms or hypoglycemic symptoms for safety. And I will say that using this intervention for me personally has kept them quite intact. And the better my glycemic control is, the more aware I am when I go low of those symptoms, which is important to have that feedback, to know that you're in one of these states. It's kind of interesting when you go hypo as type 1, the way I would describe it, when you're aware of it and you have the awareness of it, symptomatic for me, it's almost like if you go low enough. I feel the same thing nowadays where I didn't before when I dive, when I have too quick of a dive. It almost feels like I have this upbeat mood. I'm talking to Christy. I'm sharing about my life story. I'm excited about this. And all of a sudden, this dark cloud starts coming over my head, just like almost like you're outside going for exercise on this beautiful day. And all of a sudden, it gets really hot and starts raining on you. It's almost like you have a different context by where you're doing the same activities, but it's just framed in an entire different environment. And it's kind of like that. It's just this big cloud of like doom and gloom, not doom and gloom, but like negativity, your affect changes. And it's not just like, oh, like you can subjectively change this. Your biochemistry induces it. So it's not like, oh, I can just feel better. It's like, well, you can ignore it. That's one strategy that often can be effective. But the reality is that you go into it, if you go hypoglycemia, you go into full stress mode. So the analogy I give people is, let's say, you're in high school, right? You're giving your first public speech ever, and you get up on stage and stand in front of 100 people for an hour, and then you get grilled by them. Imagine the stress response you might have to that. Well, that type of stress, like this catecholamine dump, et cetera, is well characterized in type 1 diabetes hypoglycemia. So, and I can tell you that feeling is very similar for me. And once you have it, a decent hypoglycemic moment within a day, for me personally, and I spoke to other type 1 diabetics who shared a similar feeling, you don't ever really recover. If you have that really, really stressful moment, let's say someone says you're fired, from your job, or you have that big speech, you have all this stress. After it's over, you don't go back to feeling like great and normal. You kind of need a full-fledged recovery to like the next day before you can kind of feel fresh again. The reality is that's how it is. If I ever had a real severe hypoglycemia, I don't really feel normal till after I wake up the next day. So it lingers for a long period of time. And imagine most people with this disease, and this is where I get more on the advocacy soapbox, most are living there on a regular basis, not necessarily in hypo. Most people actually avoid that at all costs and live hyper on a regular basis because they're so concerned about the acute adverse events to hypos. But yeah, as you mentioned before, and the data supports this as well. This is why I feel more comfortable talking about this as a researcher, because I'm not alone by any means. That actually largely supports that, at least in the limited studies that have been conducted, the more carbohydrate you restrict and you manage appropriately with insulin adaptations, the less you're going to see these outside of time and range is what they call it, et cetera. So it can definitely cull that. And we also know that the amount of incidences outside of normal range does go down, but we also know the amount, at least for the data we have right now, which we need more, but at least for the data we have right now, we know that severe adverse events, both DKA and severe coma, seizure, or hospitalization with hypoglycemia, so an intervention-based hypo, or a hypoglycemic, the required intervention, is much lower based on the data right now. So that's important. I mean, that's one of the most chronic concerns related to type 1 diabetes and management is avoiding those acute complications.
Yeah.
So yeah, it's helped me, but it's also helped other people apparently. Yeah,
no, that's obviously very important, and for the chronic long-term effects of these hypos and hyperglycemic events. But I did have a question. I don't even know if this makes sense, but if you're experiencing a hypoglycemic effect, say I was going into, if my blood glucose was plummeting for some reason and I'm fasting for 48 hours or something, my pancreas will start releasing glucagon, right? And then I will start shuttling out glycogen from my liver. Is that how I
Yes,
recover?
yeah. So you're saying when you go hypo, that's actually part of the rationale behind it, right? So when let's say you were a normal average American on a standard American diet and you didn't eat anything all day, that's not normal like we normally do. Let's say you ate, 3 big meals a day and you snack basically all day, which is honestly what the data says most people are doing. They snack a ton and eat basically all day with little tidbits, but 3 main meals. So let's say you're that person. You decide, I'm not going to eat all day. At the end of that day, you will probably experience what it's like to have mild hypoglycemia and type 1 diabetes, which is going down to like 60, in the 60s, so to speak. I mean, I can go down to the 50s or 40s like nothing if I mismanage my diabetes, and average most type 1 diabetics know quite well what that feels like. So for you, if you were to do that, yes, you would have a well-characterized stress response in that moment that would tell your body, oh wait, I'm hypoglycemia or I'm hypoglycemic. So then your body does this homeostatic regulatory mechanism by releasing the stored glycogen you have in your liver through things like glucagon, which stress hormones can help initiate, or stress molecules in your hormones can help initiate that molecule's release, which then causes the glucose bound up in glycogen stores, these chains of glucose molecules, to be released into your serum blood to then balance out the hypoglycemia. So it does require typically a stress response to induce that. That's also why, as you've seen before, Christy, one time when I got really stressed before, my blood sugar spiked up to the ceiling. I don't know if you remember that, but it did happen before. And so that can happen. And we see that in type 1 diabetes, right? If you get super, super stressed, that it can also spike up. And it is a well-characterized response that initiates the breakdown of these chains in your hepatic tissue where you store it.
Is there any changes with glucagon signaling though in type 1 diabetes? Because that's an alpha cell versus beta cell with insulin.
So I'm going to try to answer that to the best of my abilities. I think that there's to my knowledge, there is differences in this that I think are still understudied to fully understand. But I'll just tell you, fundamentally, there's a lot of differences. Like even injecting insulin is fundamentally different. If I inject this insulin into my body, it won't actually work the exact same way that it does in your body. Besides all the things I talked about with kinetics, we actually know that type 1 diabetics typically live. If I had Andrew Koutnik right here next to me, we ate the same exact meal, and I injected just the right amount of insulin for me, but then Andrew Koutnik here didn't have type 1 diabetes, injected or had endogenous release. That endogenous release in Andrew Koutnik over here without type 1 diabetes will actually more potently affect the hepatic tissue. So the problem with type 1 diabetes is that we often live in what they call peripheral hyperinsulinemia, where when we inject it from outside the body, it actually seems to saturate the peripheral tissues. It has less of an effect on the actual hepatic tissue. And we know these hormones, like insulin and glucagon, are counter-regulatory to one another. And if you have less potent impact on the hepatic tissue, that could obviously have wide-ranging implications. And there's a lot of question marks around that, of what are the wide-sweeping impacts on things like that. So it's kind of a way to describe, I don't have a direct answer for you on that. I do know that it is, both insulin and glucagon appear to be differential in their impact, and is its own field of study in and of itself. I don't know if that helps answer some of it, but.
Okay, that was a little sidetrack I just thought of while you were talking, but what do you define glycemic control as? Like what's the goal with any sort of strategy and management? What are you trying to achieve? And if you are seeing all these benefits, and the literature does support that a low carb diet may support better glycemic control over a higher carbohydrate diet, why is there so much resistance, or why isn't it more widely adopted in the clinic?
For so the second part of the question, I definitely, that'll get into a whole host of other questions. But the first part of the question was what?
Wait, I think I took two different paths there. Let's just
Okay.
focus on the second question. So what?
Okay, yeah, not a problem. And then we'll come back to that if you can remind me of that. That's my fault. So if there is this data to indicate that this dietary strategy is effective, why is there such resistance? Well, the problem is that the type of data that is hoped to make these type of widespread practical implementation or clinical decisions, what they hope to see across everything is a randomized control trial. It's a very large randomized control trial to make informed decision across how applicable would this be across population. And they're very, very valuable tools in the toolbox, right? When you think about phase 1, phase 2, phase 3 FDA clinical trials, you hope to have that level of evidence before you take an intervention. So let's say we're in a time of COVID right now. Maybe this interview will be completely irrelevant, hopefully one day for COVID-related questions or inquiries. But right now, COVID's relevant to us. So let's say you hear a lot of things about remdesivir, hydrochloroquine, serum antibodies, all those other things. And you heard like, okay, this small group of like 10 subjects over here use this intervention. Or I heard that in this group of individuals who did this reported outcomes, they had a really great success with it. Are you going to go take it immediately, or would you want the type of trial that shows widespread across the population, no matter across multiple institutes, across multiple social and economic classes, that it works for everyone on average? Well, the scientific community wants to see that latter one, not the prior. So a lot of the evidence we have right now in the very low carbohydrate diet falls into categories of, actually there is an RCT, but it's very short term, on 7 days. That's Rayhan et al. Rayhan, I hope I'm saying that correctly, et al. 2 studies came out on that. But it's short term. So not the type of long-term intervention you want. There's about 13 case reports / case series at this stage. There's 2 to 3 observational studies in that category. But people want this RCT-based data to really inform that. Well, we're not there yet. And we don't have that type of data. The problem is that you need major funding to get that off the ground. But to be fair, it's also important to mention, we've never had an intervention to describe what is optimal nutrition for diabetes ever. That type of trial we needed yesterday, not like we needed it a long time ago. It should have come a long time ago, in my opinion. I think it's extremely valuable to come forward. But the thing is, we do have data that indicates right now across these observational, these case reports and case series, et cetera, and these intervention groups and a lot of anecdotal reports, there's overwhelming success in these categories. And as far as glycemic controls, in fact, we know that almost all, not all, interventions of the very low carbohydrate data we have right now, I think 16 out of 18 actual like analyses / cohorts are actually illustrating non-diabetic numbers, non-diabetic HbA1cs. There's no therapy that does that right now. Mm-hmm. So there's overwhelming, and that's just one outcome. There's other outcomes that I could talk about that show like amazing success using this approach. But the type of data matters to the clinical community to make widespread clinical recommendation changes. And that's understandable that they would want that. But a lot of the criticism is like, well, then why are they doing a high carb diet? Like, why is the average recommendation right now to follow the normal population without that data? Well, I don't actually know that answer. Well, I don't know why that actually is the recommendation, other than, well, if we don't have the data, do we just follow the normal population? But the reality is that the biochemistry of my disease and the physiology that accompanies it and the management of it is so different from the normal population that just giving normal population recommendations is not probably smart, in my opinion. Just because if you give the normal strategies, we know that the things which can accompany that. But that's just my opinion. People will certainly disagree, and it's worth reaching out to hear what they have to say on that. But there is a list of things that the clinical community or otherwise has been concerned about when it comes to low carb diets. One of the first ones is hypoglycemia. The idea that if I were to give less carbohydrates in the diet, won't I risk going hypoglycemic more often? And what we know is that the risk factors for hypoglycemic events and severe hypoglycemia is actually elevated HbA1c and glycemic mismanagement. And we know that based on the evidence we have right now, we call it limited or whatever, it's low, those both go lower. So glycemic management goes down, it's improved. And HbA1c has repeatedly come down across these studies that have come out on very low carbohydrate and type 1.
We actually know that there's some studies that actually show the incidence of the actual outcome decreasing as well compared to general population type 1 diabetes norms. So we actually know that based on the evidence we do have, that it's actually lower. Now, what about for DKA? So DKA is another concern because people think, well, if you're already on a diet that potentially elevates ketone bodies, aren't you at elevated risk for going into diabetic, full-fledged ketoacidosis? Well, one, it's important to find that these two states are completely different. One is a pathological event, and one is a normal physiological outcome. We know that when you reduce carbohydrates, or even go into a fasting scenario, like every endocrinologist knows this. When you restrict carbohydrates or fast, that you increase ketogenesis. It's a normal part of our physiology. We know that the description that once carbohydrates come down in the diet, that your body actually, as glucose lowers, then that triggers insulin to lower. Once insulin lowers, this is really the trigger for glucagon to elevate, cortisol, catecholamines to elevate, to then cause liberation of adipose tissue, free fatty acids, to then generate things like ketone bodies in the fat tissue. So insulin's really kind of like the brake on those things that kind of get lifted off. Every endocrinologist knows that that's the case, and that's how the biochemistry of that works. I think when we're talking about, carbohydrate restriction or the mechanism of action described to that, when you talk about things like DKA, yes, you are producing ketone bodies potentially at higher levels, and that really depends on the type of diet you do. Are you doing higher protein, low carb? Or because that tends to require a little bit more insulin and then blunt the amount of ketone present? Or are you doing full-fledged, like ketogenic style approaches? And understanding that this is actually a normal physiological response is also important. But the risk factors that we actually know contribute to DKA actually go down, which are the same risk factors for the hypoglycemia, HbA1c and glycemic mismanagement. And both of those go down. So the risk factors go down. And we actually know that based on the evidence we currently have in very low carbohydrate diets, that the actual outcomes, so actual outcomes in DKA go down compared to general population norms in type 1 diabetics. By I think about, it goes from about 3% to 1.3%. So a decent reduction. The amount of incidence of hypoglycemia go from around 5 to 15% down to, I believe, less than 1%. So a pretty robust difference there. Actually, multiple magnitudes of difference. Another concern is revolving kidney health. So a lot of people on this low carb diet tend to have more protein. It makes it more compliant for some individuals. And obviously, a lot of people aren't chasing ketone bodies on type 1 diabetes. They're just chasing normal glucose levels. So a lot of people like to have more protein in the diet. And it's actually a common used strategy across a lot of people using strategies like the Bernstein method of diabetes solution. They have higher protein and kind of fat comes along for the ride, but of course restricting carbohydrates to green leafy vegetables, ideally around 30 grams. That's that prescription. Well, we know that when it comes to like protein levels, that at least in the general population, actually Stu Phillips, someone you said you interviewed previously, I know you have, he has actually part of a meta-analysis that showed that there's indications, at least in the normal healthy population, that higher protein levels don't necessarily exaggerate kidney dysfunction. It's probably something maybe he touched on with you, I'm not sure.
Yeah, he did.
Okay, so there you go. So look at Chrissy's other interview with Stu Phillips, who addressed this in the normal population. But the concern is in what about diabetics who already had increased risk for kidney dysfunction, where there is some evidence that there might be some use in restricting carbohydrates once dysfunction is already present. However, we don't have data right now to indicate that that's actually the case in type 1 diabetes and that it would be even relevant in this situation. So there isn't actually evidence to support that concern or risk factor right now. A very, very big concern that is commonly brought up is, what about kids? There's some evidence in seizure patients who went on a very restricted low carbohydrate diet, 90% by kcal or on that extreme spectrum, that a percentage of those kids had growth impairment compared to the normal population curve, growth curves. There's also been a case report out of Australia where they actually looked into the community and said, hey, we want to study these diets. We want to find out, have you guys ever experienced adverse events with low carb? So they looked specifically, are there adverse events on low carb? And they found 6 people who were willing to give them information on adverse events. And they looked at growth and body weight curves. And they did indicate that some of what they were concerned about was the growth curve. Like they showed growth impairment curves in this case report where they specifically looked for adverse events. Well, the question mark around that is, Well, if you didn't look for them, what about everyone else who was doing it who didn't have the adverse event? So that there's levels of evidence by which people are wondering, is this a concern? But if you consider the pediatric paper that came out, which had a New York Times article about it, looking at a survey of a group of individuals with doctor-confirmed data, so they actually confirmed with their doctor that the results they were saying did confirm, and that they were able to show that. This was probably one of the most groundbreaking studies in type 1 diabetes, illustrating that there was a group of individuals who were able to achieve levels of glycemic control and other biomarkers that were unprecedented. And that was a pediatric paper by Belinda Leonards and her team at Boston Children's at Harvard. And hopefully we'll more follow up on that type of work. But in essence, they were showing that, at least in those groups, that there was no growth impairment against the normal population growth curves. So there's this host of counter evidence right now about that. And I'm sure that people still view that as an open concern. But the reality is that the evidence doesn't support it one way or the other. We don't know the answer to that. I think it's important to acknowledge that glycemic mismanagement, we know, disrupts normal growth. So if you have poor glycemic control, that also is a contributing factor to growth impairment to even begin with. It's a set precedent, right? So if the average outcome of type 1 diabetes is glycemic mismanagement, like it is adverse HbA1c levels, and that does contribute to growth impairment, or that's like a set foundation right now. So if that's a concern, we also consider what are the benefits this diet can give just to that foundation alone. And is it justified beyond that it'll have growth impairment if you restrict carbohydrates? Because insulin is a hormone of anabolism, right? So if you reduce this anabolic hormone, is it going to impair growth? And we don't have that evidence right now, but that means we also shouldn't necessarily say one way or the other that it would. But we do know it improves glycemic control. So, and we do know that is associated with adverse pediatric growth. But hopefully more research on that to come for sure. There's also the question about, chronic health with doing a high-fat diet, because there's been evidence in the past to say, well, if someone has a higher fat diet, isn't that going to put them at risk for cardiovascular disease or other things? That's really the focus of long-term health, is cardiovascular disease, especially in this population of diabetes. But the best evidence we have right now in cardiovascular disease comes out of a 2016 study from the DCC and EDIC data. Now, for those who aren't familiar with the DCC and EDIC, it was diabetes complication complication trial, and EDIC trial was a follow-up to that. That was the most well-done, robust study that we've ever had in type 1 diabetes. Over 30 years, 1,400 participants across multi-institutional sites. And they looked at the data in those individuals across what are risk factors for cardiovascular disease over this 30-year period in over 1,000 subjects. And what this data set found is that HbA1c was the #1 risk factor for cardiovascular disease. They knew things like hypertension also are important, but triglycerides were also very important. So higher triglycerides contributed to adverse outcomes in cardiovascular disease. Other risk factors as well. What was interesting, if you look at the hazard ratios of things that often are looked at in risk factors for cardiovascular disease, like total cholesterol, LDL, and HDL, the hazard ratios were almost equivalent to 1. Now, that's not to say that they don't matter, but it's just to say the best data set we have, which is limited. We don't have a lot of other evidence to say one way or the other in type 1 diabetes specifically. But in the evidence we do have, it does indicate that the hazard ratios for total cholesterol, HDL, and LDL basically are equivalent to 1. So that's not to say that those don't matter, but they seem to matter a lot less than things like HbA1c, glycemic control, or triglycerides, or in controlling hypertension, et cetera. So that's a long-term concern related to cardiovascular disease. And the reality is that, the analogy given would be something not novel to something I'm saying here, but if you have a car and you have an engine that doesn't work, are you going to put, you're going to worry about how shiny the rims are? Or do you worry about the engine first and then consider the other factors as secondary, tertiary, et cetera, factors to then consider? Glycemic control has sat atop the mountain of most important factors to control in this disease over everything else, and probably will for my lifetime. So at this point, that's what matters. So if you control that first, then we can start considering other factors, where if you consider lipids and other factors controlling the cardiovascular disease, the one that matters the most of all those in that data set was triglycerides. And we actually know that in most populations, lowering carbohydrates lowers triglycerides. But we also know that elevating carbohydrates can elevate triglycerides. So if this is an inadvertent benefit to risk factor associated with this strategy specifically and actually controlling outcomes cardiovascular-wise, at least biomarkers of outcomes associated with cardiovascular disease. Again, we don't actually know. We need a trial to say, you do this diet and this is what the outcomes will be. That is long overdue and needed. Like it's long overdue and should have been needed a long time ago. But the reality is we don't have that. So what do? We look at the risk factors associated with it in type 1 diabetes. And then we look to see how does that change with the diet. And we see that those tend to actually lower. And ironically, if you actually look across the data right now, total cholesterol on a very low carbohydrate diet directionally goes down. LDL has mixed results and HDL repeatedly goes up. This is what you would expect actually in the general population. A lot of people think about higher fat intake, saturated fat intake, LDL goes up. The reality is if you look in type 2 diabetes data and type 1, yes, there's evidence for that, but the mean across studies actually doesn't illustrate a directional effect. It's really all over the place and person by person dependent. So when we talk about this, we're talking about hypoglycemic episodes are concern, DKA is concern, pediatric growth is concern, cardiovascular disease concern. You know, but there's the other two major concerns are, one is compliance. You know, is someone who goes on this diet, is it even like possible to stay on it? You know, isn't it possible that if someone does this diet, it won't even matter because they can't keep up with it? Well, there are two things to consider with that. Is we don't know right now whether patients are going to stay compliant or not. The reality is that when you look at any lifestyle interventions, low carb doesn't sit on this at the top of the threshold as the non-compliant intervention compared to other diets. It actually sits right along with all the other diets, right about the same. That patients who do this diet have a percentage non-compliance rate. Interestingly, if you actually look at the VERTA data, which is interesting in type 2 diabetes, we see that in type 2 diabetics, that they actually at 2 years out, I believe, had about a 50% retention rate. Now, a lot of people might say, well, that's half the persistence you didn't stick on 2 years out. However, the chronic, to my knowledge, and I could be wrong here, someone correct me, I'm sure they will, but I believe that with chronic medication use, the compliance rate with chronic medication use is actually only about 50% as well. So, so we know that no matter what, if you do a lifestyle intervention, it doesn't matter if it's food or exercise, compliance rates aren't going to be perfect. But there are things that can be done to improve that. VERTA seems to be a great, unique way that has shown to be able to do that in type 2 diabetic patients. And I'm sure there's other ways in which you can do that. It's not for free. But a lot of people look at this as, I'm changing my lifestyle, so I won't stick with it as long. Well, one thing that really needs to be considered, and this is not data-driven by any means, but just hypothesis-driven in my own head, from my own personal experience, and what I've seen in the type 1 diabetes groups who tend to follow this with higher compliance, is with type 1 diabetes, if I go eat a certain food or do something that causes me to have hyperglycemia or hypoglycemia, I feel the effect of that pretty acutely. So I can feel that within minutes to an hour of whatever thing I just did. And that effect doesn't go away immediately. It will potentially have a minor or major impact on the rest of my day. So there's biochemical feedback on my choices every day. And food's obviously a huge part of that. So there's something in my head that has always been wondered is, can disease outcomes actually improve compliance? And that's usually not the direction by which investigation usually flows. It usually flows as, okay, if you change the diet, our compliance level is different. But there's very little on the opposite. And we know these are bidirectional. So at least it should, and by all theory it would be, is that what if someone changes their disease outcomes? Can that alternatively improve compliance? And that's an open question. And I forget what the last one was, but in essence, those are the main things that are often brought up in the context of type 1 diabetes related to hesitation for full-fledged implementation of various strategies. And one thing that's important to note here is there's been huge, the patient interest. That's another part of compliance is, we know the patients, the thing is, everyone should do whatever they want. It's not me to tell them this is better or worse, but you should know that tools are in the toolbox and you should know what those are. And this is one of those strategies. If we're talking about carbohydrate restriction specifically, or very low carbohydrate or whatever. You just know that what those tools are and what they seem to do is important to know. And also know that with strategies like that, there's a ton of resources available nowadays to not give up traditional food options, right? So I might not go eat Papa John's, hopefully ever again. You know, like maybe I'll never do that ever again. I'm not saying anyone shouldn't do that ever again. If I don't ever do it again, I'm not gonna be mad at myself. I'll be fine. Because I can essentially remake all those foods. It might not taste just like Papa John's. I'm not gonna anyone about and say I can do that. What I will say is that you can make birthday cakes, you can make cupcakes, donuts, all the foods that you think you're giving up forever. In reality, you can remake those. I'm not advocating that anyone should make that all or most of their diet. But what I am saying is if you choose a dietary strategy like this, it's really more of an education thing as to learning how to make it a lifestyle that is sustainable. And I've made all those foods I mentioned to you without having any glycemic excursions. And at the end of the day, that's my goal, to live the highest quality of life, get the most years on my life, because I also have a 17-month-old son who I want to be around for a long period of time. And all the data right now says with type 1 diabetes, I'm supposed to only live 11 to 18 years shorter than my average general population peers. And I do not plan to live 11 to 18 years shorter than my peers if I have any control over it, not only for myself, but for my family. So that's my perspective. That's my viewpoint on this, and kind of how and why I approach this problem the way I do. At the end of the day, if there's something better that comes along, guess what Andrew's going to be doing? That. But until that day comes, I use the best stuff we have. And so far, this is something I do, and it seems to work pretty well, not just for me, but a few others. So.
Wow. Yeah. So many questions popped up while you were talking and probably forgot half of them. But no, I love what you say about the adherence and compliance and everything, because it should be an option. It's almost like taking away a tool from patients without giving them this knowledge, or just having it presented as an option, regardless of the opinion of the physician. It should, like all type 1 diabetics should know that it is a valid option, and whether they want to pursue it or not. But yeah, everything you mentioned, all of the health related concerns with following a low carb diet, literally every single one that you mentioned was made worse with worse glycemic control. So it's just interesting when you find.
Because actually, you're right. DKA, coma, seizure, growth impairment, severe adverse events. The only one that's really outside the realm of that is compliance, which we really don't know the question one way or the other. And actually things like quality of life, we see at least the data is very, very biased right now. But in those patients who at least choose to do this intervention have improvements in quality of life. And those are the real endpoints that we've actually seen meaningfully assessed is DKA, coma and seizure, and quality of life. And those have actually all improved on this intervention. But the biomarkers of risk for the other things that have been mentioned seem to improve as well. And things like kidney function, if you're even concerned about protein and kidney function, you have a choice. You don't have to have high protein versus low protein, et cetera, et cetera. But it's largely irrelevant if you don't control your HbA1c first. Because that's clearly one of the most potent risk factors on kidney dysfunction is HbA1c outcomes. There's really no refuting that. And I think that the evidence is, I think I'm not making any controversial statement when I say that no one's going to make an argument that protein is more important to your kidney health than your HbA1c is in type 1 diabetes. So yeah. I didn't think of it necessarily that way, but you're 100% correct. Yeah.
And on note of ketoacidosis, so are you concerned about ketoacidosis at all, or do you have any sort of strategy? Because there's a difference between zero insulin and management of a low carb diet with insulin. You're still taking insulin. Correct. So is that enough insulin to prevent ketones from elevating too high?
Yeah, I mean, think about the normal population. So you don't see pathological elevations of ketone bodies. Anyone doing a low carbohydrate diet in the literature, I mean, there really isn't a case for that. And the only time you ever see that is when people take medications like SGLT2 inhibitors, or in very rare cases where patients have some other event that increases their metabolic rate into an elevated rate that's often uncontrolled, like they get sick, breastfeeding, or other scenarios like that. Those are the rare case reports where you see euglycemic DKA, which is really what we're talking about here. If you have direct glycemic control with type 1 diabetes on a low carbohydrate diet, is there a risk for having normal blood sugars but elevated ketone bodies in a pathological fashion? Now, your question is, second to that, am I concerned about that? No, I tend to do it on the higher protein spectrum of the low carbohydrate intervention. I have done the other. I've done full-fledged like keto hardcore. I've done the higher protein version just because my goals right now are largely driven. I do a lot of resistance exercise, and protein is pretty important to those. And I definitely can see a difference. I personally tend to fall within the mean averages of, someone does resistance exercise, it's probably better to have higher protein. If you do aerobic exercise, and the different fuel sources, et cetera, so it may not be as important what you do or don't do. But yeah, I tend to fall in the high protein spectrum of that. So my ketone levels probably sit around 0.5 for the most part. They're not really meaningfully going higher than that. But what's interesting is, to me, I'm not concerned about it at all because largely it doesn't really get out of control. But the only cases I've ever heard of, or in the literature that really illustrates that this even happens with people who do this strategy, well, one, there isn't really any literature on type 1 diabetes and low carb. There's very weird reports and case reports where someone who actually didn't have confirmed type 1 diabetes got some like pathological beta cell issue for like a week, then were on SGLT2 inhibitors and on low carb combined, and they got the euglycemic DKA, but the data didn't confirm that. There's just weird data around that. So we don't have good data on that right now. But it doesn't mean you should ignore the possibility that you could go into euglycemic DKA. I have heard some anecdotal reports from one person that they got euglycemic DKA confirmed by other biomarkers, but they were fasted, got sick, and were doing low carb all at the same time. And so that's a number of factors where they already were doing fasting, which isn't low carb, by the way. That's reducing insulin to almost nothing. And on top of that, they were also doing, they were already doing low carb to begin with. So then they fasted and took the insulin levels even lower. They got sick, which elevates metabolic rate. So that's a recipe for potential risk for something like that. So in all reality, everything says it's possible. But most of what commonly drives that effect is not ascribed to a dietary choice. It's largely, if you stop taking your insulin, it's your biggest factor. You stop taking your insulin, that will certainly cause DKA pretty quickly. But I don't worry about it because I don't get to follow a diet where I even be remotely at risk, even in the therapeutic threshold, so to speak, that term, somewhere between, let's say 0.5 and 5 millimolar.
I have a question though about when you were doing full-blown keto, were you experiencing were you experiencing symptoms of hypoglycemia if you were in ketosis? Because are the symptoms related to just reduced glucose and reduced metabolism in the brain, and you're not getting fuel to the brain? But if you're in ketosis, would this kind of mitigate any symptoms of hypoglycemia?
So that's a interesting question. So they've done some studies in obese and or mild diabetic patients where they fasted them for over 30 days. I'm sure you've heard of this study. It's been talked about a lot. There's actually more than one of these that have actually looked at this, not just George Cahill and his unpublished data showing this. There's actually other people who published it in 1970s as well, showing that when patients go hypoglycemic, these patients who are obese and diabetic go hypoglycemic, and they, not hypoglycemic, but their levels, mean blood glucose levels reduce, their insulin becomes extremely low. And then you give insulin to these subjects. These are diabetic patients, well, at least some of
The Cahill ones were not diabetic.
What's that?
The Cahill study, whether they gave and pushed glucose.
They tend to describe them as, in some of these other studies, as like mild diabetic patients.
Okay.
So like this idea that they were overweight and obese, et cetera. So, and a lot of these studies, these older like 1970s studies, late 1960s, describe these obese patients who are going on these diets as mild diabetes. So I don't know how that would line up with our definitions today, but that's how they define them. They did this long study, they fasted them, they went into nutritional ketosis. Some unbelievable levels of ketones were achieved. Some of the highest ever reported that I've seen, actually up to 14 millimolar in some of these reports. That's the highest I've ever seen ever in any normal endogenous production. And but the average was around between 6 to 8 for most subjects. Either way, they injected insulin to these subjects, and they saw that they had hypoglycemic protection. across both those analyses. So that opens an interesting question. Is there the possibility for hypoglycemic protection in the context of ketone bodies? Because we know that in these scenarios, George Cahill and his brain and starvation study, basically Owens, one of his research collaborators who did this study, I think it was 1967 or 69, but I think it's 67, where they actually showed the uptake and use of ketone bodies across the brain during fasting, and showed that it was highly elevated in the nutritional ketosis scenario where glucose levels were on average lower. And then that his secondary follow-up study, which never got published, which was in a book, where they gave insulin and they got into dangerously low levels of glucose. In fact, the one study that I'm referencing in 1970s, I think 72, but in the 1970s actually showed that they got as low as 9 milligrams per deciliter. I can tell you right now that would, in the average scenario, when you went that low, it could be extremely dangerous. Honestly, not extremely, it could be. It is extremely dangerous and could be fatal if you're asymptomatic. So that does open that question, but the reality is that there is an open question to that. The biochemistry suggests such things. I mean, I will just say that I've seen some indications experimentally that, not myself per se, because I never really pushed myself to that sub-threshold that low. I didn't really want to roll a dice like that. But the science all aligns with that's a possibility. I've had some preclinical studies showing similar things to get to fatal neuronal death levels, and there was protection elucidated from that. That, you know, we actually haven't published this, but that's out there. So everything really lines up to say that that's possible. So that really, and actually, ironically, I don't know if you know this, Chrissy, but when I first met, some of you who were listening to this may know Dominique D'Agostino, who I did my PhD with. And the first thing I actually asked him when I first met him, which was a year and a half, 2 years before I started my PhD, we started talking about this diet strategy, right? And this is when things really started kicking up with the research that he was doing with Angela Huff at USF College of Medicine. And I just met him in the Hypoglycemic lab, which a lot of, I'm sure if you're familiar with him, you're familiar with, he does seizure studies as well, neuroscience-based work with ketone bodies. And the one thing he says, like, okay, we have this shift in fuel, et cetera, et cetera, et cetera. I had no idea about any of the literature on this topic. And I was like, wait, you're telling me that one person were to do this diet, they could shift their fuel from glucose to ketones? And he's like, well, yeah, there's some evidence that that's the case. And as a type 1 diabetic, before I even knew of any of these studies at that time, I was like, man, that'd be incredible. Because you imagine a diet that is able to actually provide protection against the most concerning outcome, adverse outcome in type 1 diabetes, which is hypoglycemia. That is ultimately what is usually the cause of acute end of life in a patient, or one of the most common reasons where a patient passes away much earlier than predicted survival. On average, that's one of the main reasons. So if it can provide a nonstop endogenous protection of that, that'd be everything in one, right? You have this glycemic control, you have this hypoglycemic protection potentially, and if you're able to mitigate other risk factors, it seems amazing. Well, we'll see. I know hopefully there'll be more research on that topic. I don't want to say explicitly just because it happened in those scenarios outside of type 1 diabetes that it would work. We don't know. And it's also dangerous to hypothesize that it would, but there's a lot of tools in the toolkit, so to speak, surrounding that concept that may further elucidate or help with those topics. There was a study in 2008 or 9 by a guy named Richard Sherman, who actually a really prolific guy. Actually used to work with some of the individuals who used to work with Cahill back in the day. He was at Yale. He just recently retired, I think, in 2018. Did a lot of work on this topic, especially related to skeletal muscle and also the brain. And they did MCT administration prior to the hypoglycemic event, and there was cognitive protection in those participants. So long way of saying that's everything that we're aware of right now in the literature on that topic, and we will see in the future. Who knows? Maybe there'll be more research on that topic.
Yeah, so interesting. Do you ever experiment with exogenous ketones? Is there any issue with taking exogenous ketones?
So have I experimented with them? Yes. I like to do self-experiment. So I've played all around with various types, options, et cetera. I definitely think that there's an interesting place for some of these molecules for diabetes management and or strategies. Are there concerns with them? I think when you're talking about concerns, related to ketone bodies, most of the concerns will be involved, does it exaggerate DKA, or does it exaggerate ketone levels in the blood if someone's on a dietary strategy like this, or et cetera, because a lot of it, it's a biomarker used in a standard diet with giving these molecules. So that would be the hesitancy revolving that, but I see no reason why, if someone wasn't in a pathological situation. By the way, I'm not a clinician, I am not giving clinical advice previously or now when I say this, but I don't see any reason why they're inherently dangerous for a type 1 diabetic any more so than would be for the general population, only with the exception of consideration that it does elevate ketone bodies, and that must be considered that if you're taking a molecule that directly elevates in very rapid form ketone bodies, that it doesn't mean you're a DKA all of a sudden, right? So that would be my biggest thing worth noting there. But I think their place in type 1 diabetes is absolutely an open question. And we will see if there is a place for them. I think there's potential application, but it's an open question. It requires research, and we'll see.
Is there a glucose lowering effect to exogenous ketones in type 1 diabetes? Like, have you experienced that? Like, because there is a normal person.
Yeah, so that's a very, there's a lot of evidence when we're talking about this, revolving the hypoglycemic effects of exogenous ketones. I am a believer that there is evidence to actually illustrate that in rodents. We've actually done some of that work. And we actually see some evidence of that in patients as well, in some of the research out there. I will say that I have taken exogenous ketones. It requires a particular potency of the ketone to actually do such a thing, but there does appear to be a glucose lowering effect upon ingestion or administration of some exogenous ketones, maybe all, I'm not really sure, but I did try some before, specifically esters, and I will say that it has a very predictable drop in glycemic or blood glucose levels. And actually, there was a study by some years back, where they actually looked at patients with type 1 diabetes. And I believe they did it via IV infusion. And this was without changes in insulin. At least they didn't indicate they had changes in insulin. They controlled the environment. And they also saw a glucose lowering effect in that environment. So I am a believer that, and so we have very limited evidence in type 1 diabetes. We can't just look at Andrew's situation and say that's going to happen. But there is actually some evidence, and it is limiting. It's in a small core of type 1 diabetics without insulin administration, giving ketones via IV infusion, and they saw a lowering as well. So, and we also see this in normal populations additionally. So there does seem to be an effect there. I do believe it is happening. These are all topics that you're bringing up that I think could validate some of the most important research questions revolving this space. And if answered, would provide additional credence to the idea of using strategies that we know people are doing anyways, like nutrition and various tools in the toolbox, like supplements, et cetera, to manage disease states. And it's something that I talked about when I did that TED Talk some time ago, was we know these are tools in the toolbox. And as you bring up a lot of these things, I just wish, and I think many people wish in this field, that tools this effective or shown to have this level of effect should also have the level of research funding to support them as well, and to do more research. It is a controversial topic because it almost has become like villainized, the idea of funding or not funding research for these topics. At the end of the day, more research is only going to be more informative. It shouldn't be used as ammunition one way or the other, although it is. It shouldn't be, but it is. But at the end of the day, these are things that all these things you bring up open new questions, which I think illustrate some of the most important questions that could really, I think, improve lives of type 1 diabetics, or at least tell us how to further optimize tools we've seen work for type 1 diabetics. In that case, will apply to all. How do we optimize them to better fit? Or is there one strategy that's more effective than others in the short, medium, or long term for type 1 diabetics? And are some people uniquely applicable for it and some not? Are some at risk if they do this uniquely? And that's kind of an open topic right now, looking at lipid levels in people who do low carb. And some people have these exaggerated responses on carbohydrate restriction. And I don't have a stake in one way or the other on that answer, other than to say that it does open the question of is it really the strategy for everyone, or is it a strategy that should be caveated based on how your response to it is, you know?
Yeah, but at least we would like to see it as an option, I think, in my opinion.
I think as more options, the better. I mean, obviously there's a counter to that. When you get too much options, you don't know, it's paradox of choice, you don't know what to choose. But I think at this state, we don't have tried and true hallmark therapies that just repeatedly work and improve outcomes in patients. When you have a medication, you hope that it's able to control the disease. So if I get diagnosed, so Christy, if you got diagnosed with a disease tomorrow, you hope that there's already therapeutic outcomes out there that give you the shot to normalize your outcomes based on your risk biomarkers, et cetera, and or whatever it looks like, you know, outcomes, risk factors, et cetera. And in type 1 diabetes, we don't have that golden bullet yet. We don't have that strategy that everyone accepts. This is it, and this is how you can do it. You see patients who have exceptional control through their individualized therapies, but we really need better understanding as to what is universally applicable right now for a patient, because we don't have a cure right now. We don't have a cure necessarily in an experimental study that's anywhere close to getting to the point where it's going to be applicable to someone like me. So I think having therapeutic strategies that are here and now and available to all patients is critically important, because even something like, say, carbohydrate restriction, it's that thing. We do see evidence that at least we know right now, based on evidence, that there is a population of individuals across the world, across research groups, and across scenarios that have illustrated that they're able to achieve unprecedented non-diabetic glycemic control levels. So we do know that right now. So the next question is, you know, people are going to ask, well, how widely applicable is that if you just give it to the average person? Well, I don't know. That should have been studied a long time ago, and hopefully will be studied by someone who's really eager to potentially have a groundbreaking therapy. I don't know, we'll see. At least the evidence indicates that. But I think that type of work is important. At least it's more informative. You know, the more evidence we have, the more informed we can be about our choices. And so I'm a big advocate of that. Everyone's got their own stake in that, but that's the way I do it.
Yeah. Okay, one last question before I let you go, because this has been a very long discussion. It's been awesome. I still have so many questions, but we're taking up way too much time now. So I was curious of, if you have been on a low carbohydrate diet for so long, do you see any markers of physiological insulin resistance? Like when you add carbs back in, if you were to eat a high carb meal, would your insulin change versus if you were just on a normal standard high carb diet?
So there is some evidence that some people can get not pathological. I don't know if the term is appropriate to even say pathological.
Physiological.
There you go. Much better. Thank you, Chrissy. The physiological insulin resistance. And so there is some evidence for that in people who do this dietary strategy. And what is often discussed around that strategy is, well, you are tailoring your nutritional or metabolism towards a specific metabolite or metabolites, fat or fat metabolite end products like ketone bodies. So it makes sense that you'd be more appropriately able to metabolize that, maybe less appropriately able to metabolize glucose, and this fasting elevation and glucose levels in individuals, and it's been reported. So, you know, when we talk about physiological insulin resistance, there does seem to be some people who have that, but we also see a lot of scenarios where individuals have an overwhelming reduction in their insulin load going on the strategy from where they started. So meaning, like, if someone so we see reports anywhere from 30 to 70+% insulin, actually over 85% insulin reduction. Actually, like something else. So I think I do know that we have about 30 to 70% spectrum on insulin need reduction. I had that. So we do see the insulin load is more predictably lowered when someone goes on a carbohydrate-based strategy, especially in the type 1 diabetes population. But if there is pathological insulin resistance, yes, there's evidence for that. I don't know if there's any evidence of that in type 1 diabetes outside the animal.
Do you mean physiological when you just said pathological?
Thank you. Yes.
Okay.
You got to keep correcting me because I might keep slipping in different verbiage that might not be appropriate. So we do know that there's physiological insulin resistance outside of the type 1 diabetes scenario. I really don't know how I don't know if there's any evidence outside the anecdotal scenario where someone says, no, I've had this happen to me, but we don't know all the factors that went into it and they weren't controlled. I don't think there's any evidence in type 1 that that's necessarily the case, although I would assume that if you see it in other scenarios, it's possible in type 1, although we do know that the insulin dose lowers on these strategies quite repeatedly. So, so is it possible? I certainly imagine it is if it's been reported in other populations, but we don't, to my knowledge, have evidence indicated that's like a universal phenomenon or even close to an even common phenomenon in type 1 diabetes. What we do see as common is insulin dose by total load and by body weight lowering. So that'd be my thought on it. But there is one caveat that may change things in type 1 over, let's say, the general population, which is there's this scenario where type 1s, if they do a dietary strategy, if they're on, let's say, a basal insulin or a pump or something like that, that's not augmented by a closed loop system or something along those lines. A lot of patients take a basal insulin or their pump provides a basal insulin. So they're actually saturated with insulin all the time. And it's peripherally higher than the average person would be as far as what tissues it exposes to insulin and then where the glucose ends up going to. Adipose and skeletal muscle being really critical and common ones that they go to. Skeletal muscle being a prominent one. And so things are different. We also know that in type 1 diabetics, these longer acting insulins, there's very limited evidence on this to my knowledge, but I have seen at least a report indicating that patients on type 1 or on certain insulins, so ones that are more acute versus chronic, that the acute insulin dosages tend to have less of a chronic impact on metabolic flexibility, while these chronic doses, these chronic insulins may have some effect on your ability to be metabolically flexible, so to speak, between fuel substrates. And that's an open question because let's say, Chrissy, you go on a low carbohydrate diet, you fast or do one of these things. In theory, you could go to pretty low levels of insulin at certain points. But let's say I take a basal insulin. I'm Andrew Koutnik, I have type 1 diabetes. And I take a basal insulin last, in theory, 24 hours. Or I take multiple doses of a basal that covers 24 hours. Well, am I ever getting away from a basal level insulin like someone who fasts completely for maybe over 24 hours does or can? I mean, it's not getting to zero per se, but getting very low. Maybe not, ever. So there is inherent differences to a type 1 scenario where the insulin's not saturating the hepatic tissue as well and more is saturating the peripheral tissue more. And also the idea that most of the just standard practice of how people manage glycemia with current tools often leads patients to be in exposed to insulin at a chronic level that doesn't really preclude itself to these unique fasting chronic experiments without the awareness of how to actually alter the insulin strategy. Things like a pump, if you have rapid insulin in it, I've done this before, where you do chronic fast and you have a pump, you can tailor that to lower it. But with these basal insulins that are lasting hours on end, it's really hard to do such a thing. Not impossible by any means, you just have to taper according to how those kinetics work, but the reality is that you have to be conscious of it. And I'm not recommending anyone does that. I'm just saying that for my own personal experience, that's what I've seen involving physiological, insulin resistance and what it may play to. So I went in different directions and try to answer that question, but there's evidence. I don't know of any in type 1 diabetes. We know the dose always lowers in type 1, usually lowers on average across the average of studies for load and by body weight in type 1 diabetics with carbohydrate restriction.
But if you're gonna eat a banana or drink a Coke or something, the amount of insulin you would need, if you were to calculate how much insulin you need for that, it would be the same regardless of if you were following a standard carbohydrate-based diet versus your low carb approach. With the insulin.
We don't know. So we don't know that answer. That's a different question. The way I try to answer that question is what we do know. And what we do know is that when someone switched from a standard diet to a various degrees of carbohydrate restriction, we see that the directional change in insulin requirements lowers in proportion to the amount of carbohydrate restriction it appears. However, your question is the valid one, which is if you control factors and you were to have same caloric intake across dietary strategies, and you had that same code on a standard diet that you've adhered to for a long period of time, a very low carbohydrate diet, with confirmation that you're in a physiological adapted state over here. That's a whole different question about like what confirms adaptation. Some people believe it is acute ketone body elevation, RQ changes, respiratory quotient showing you have elevations in fat oxidation, glucose lowers. And there's other people who believe it's a multi-month long period of time based on other biomarkers. Steve Finney has been one to describe some of those changes that take much longer to occur. That's a whole different level of controversy. Well beyond the discussion of this, but I would say that the concept of if I were to confirm at least the short-term biomarkers like the ketone elevation, RQ changes, and et cetera, would that mean that if Andrew Koutnik with the adaptation changes shown here versus Andrew Koutnik over here, body weight all controlled, calories all controlled across these two diets, if I had a soda here versus here, would I respond the exact same or as far as insulin load for that Coke meal? Or should call it a meal because damn near it is a meal with the amount of calories in it. But I don't know. I don't know if anyone knows that answer. I'm sure people have strong opinions about that, but I don't know if we necessarily have that answer. I would actually argue that you may not metabolize it quite as well if you're always metabolizing those type of foods over here on a regular basis with insulin versus over here. But the reality is that you're describing a scenario where I'm describing a scenario where everything's controlled as much as you can. Diet, calories, body weight, things that we know play into insulin sensitivity biomarkers, activity level. Let's say you control absolutely everything and you had a Coke here and a Coke here. Well, I would imagine wherever you have more metabolism of carbohydrates on a regular basis, you might be metabolizing it slightly better at the very least. But there's also this underpin and question mark of, well, if this diet resolved metabolic, improve the metabolic health of the patient, would that help their insulin sensitivity? Whereas over here, it leads to some pathology. I'm not saying that this leads to pathology either, just to say that if you have to have something else change probably to play into it. But I think when a lot of these conversations that revolve around insulin, physiological insulin resistance in these situations, there's so much that plays into the possibility. There, as a type 1 diabetic, every type 1 diabetic can appreciate how much goes into your insulin load. Your chronic weight is a huge biomarker of basal insulin needs over time. So that obviously we know body weight and other things like that play into insulin sensitivity. I also know for myself, but also literature indicates that chronic exercise can improve insulin sensitivity over time. So there's things that control things over the chronic term, and there's things acutely that can change your sensitivity, let's say medication or sleep. We know there's some evidence in caffeine and et cetera, can all play into the time of day, et cetera, can all play into the sensitivity level. I feel like that type of question would be extremely hard to control all variables and get a solid answer out of it. And I think a lot of where people are hypothesizing right now, there's a lot of moving parts involved that have to be considered when deducing why is someone seeing what is termed physiological insulin resistance in the scenarios where they're reporting it.
Yeah.
But that's my very convoluted way to say it. I don't know.
Yeah, there's clearly a ton of factors that are involved. Anyways, we will wrap it up here. I strongly appreciate you being so generous with your time with me. We've gone for about 2 hours. This was an amazing discussion. I learned a lot and I think it went very well. And I just want to thank you so much for taking the time to sit down and talk with me.
Well, people don't know this, but I've actually known, one, it's an honor. I truly appreciate this. I'm very excited for you to take this endeavor. People don't know this. I've known Christy for a period of time, and she's actually been quite a huge help in the attempt for me to even put information out there on this topic to begin with. She's much more technologically savvy than I am. So she's been very helpful across a number of fronts and also very altruistic with her time and effort. So if you've seen anything that I've put out there, like on andrewkoutnik.com or et cetera, I try to put out like free information for people related to this topic to kind of, if I say something here, I don't want people to just think, oh, that's 100%. Andrew said that, that's truth. I put that out there for free for people to do. And a huge part of even how that happened was Christy. So helped with a lot of that and put a lot of her time altruistically to assist getting that information out there. So I owe her a huge debt of gratitude for her assistance along those efforts and others along the way. So she's actually helped a lot of people out, maybe that people don't even know about. So it's an honor to be here. I truly appreciate Christy, and I'm excited to see what you do when you get, as you help me and as you help other people beyond. So
thanks so much. And yeah, I'll link Andrew's website in the description below because he has a very, very extensive 3-part series on type 1 diabetes and low carbohydrate diet. So check it out if you want to learn anything. There's so many references. I was scrolling through it today even, and the reference list is basically as long as the blogs themselves. So definitely check those out. And yeah, we might have to do a part 2 to this, but yeah, thanks again, and we'll chat soon.
absolutely, honor. Thank you, Christy.